It is a huge, 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 huge honor to be interviewing my rock star idol and mentor, Glenn Van Ass, in so many ways. You're Canada's finest. You are Canada's finest man. And who was that girl, that movie star girl from Canada? Pamela Anderson. Isn't she from Canada? So you're the male version of Pamela Anderson and Jim Carrey and all that stuff. But we both graduated from dental school in 1987. Even though you look like you could be my oldest son. But Glenn, you're looking great. I'm a huge fan of yours. You're always at the cutting edge. I wanted to nail you down tonight on a couple of things. If I ask people what you're associated with, they always say quality dentistry, case dentistry. I mean, your dentistry is rock star dentistry, no doubt about that. But I would say your unique selling proposition is you seem to know a lot about lasers in dentistry, microscopes in dentistry. So during this hour, I want to kind of pin you down on that. And I just want to start with this, Glenn. Let me start. The first question is, I've been in 1,000 dental offices, and I'm 52. And my God, if that dentist is under 35, Glenn, they never wear loops. They just never wear loops. I mean, they really believe that I wear loops because I'm an old, fat, bald guy, grandpa with a 3-year-old granddaughter, and that's why I'm wearing loops, because I'm old and dumb and senile and can't see. But Glenn, is that really true? What age would you recommend that dentists start using magnification, whether it be loops or extreme magnification microscopes? Talk, every year 5,000 dentists pour out of dental school. These podcasts are listened to around the world. I've never seen anyone wear magnification in Africa. 99% in Asia. I think I've seen one guy in India with magnification. Glenn, do you have to be old, fat, bald with a grandchild like me to use magnification?
Howard, it's a great question. One of the things that's interesting is when I graduated in 1987, in British Columbia, probably less than 50% of people had any magnification at all. Now I probably in British Columbia you're looking at 80 to 90%, and it's not just all older doctors. One of the interesting things we found is the hygienists that are graduating from the hygiene program, they're being asked to buy loops at the very beginning when they first start, and they're asking why. I can see fine, but it's not only about seeing, it's also about their ergonomics, trying to sit upright and save their neck and back. So it's not only about quality of dentistry and precision, it's about ergonomics. It's about being able to deal with very, very technique-sensitive materials that we have right now. And magnification helps anybody. So even a young graduate just out of school, I really think you should start with 2.5 power loops right when you get in school or just shortly thereafter.
It's funny. I just got off the phone with my dental school classmate, Greg Holmes. Love that guy. And he was saying, we were joking about our age. And he said, I wish when I was a younger kid, I would have read the owner's manual about my human body a little closer. And your head is a 10-pound bowling ball. And yes. I trashed my neck. And starting 2 years ago, after going to a chiropractor for 10 years and no relief, I started doing hot yoga. And I do hot Bikram yoga 3 or 4 times a week. And it's all because I completely jacked up my neck. So yeah. you young kids trying to do direct vision and turning your head at a weird angle, your spine isn't going to do that for 2, 3, or 4 decades.
No, it's interesting because my dad was a dentist. He graduated in 1961. And part of the reason he retired was he was really getting some severe arthritis in his neck. And when he first graduated, they were doing stand-up dentistry. And as time went on, he started to wear loops. I graduated from dental school and started wearing loops right away, 2.5 power. I was 25 years old. And really found that I'll tell you the story of how I started to change from loops to higher magnification. I actually had a patient come back to see me upset because I had missed a canal on an upper first molar. And he went to a specialist. When I told him I can't see anything that's wrong, I found 3 canals. He went to a specialist and he had a microscope. And he came back, he said, I want my money back, you missed a canal. The specialist showed me. And his parting words were, he said, maybe if you do root canals, you should invest in a microscope as well. And that was in 1996, and I had been graduated for 9 years. I felt devastated. I thought either I'm going to quit doing endo, or I'm going to actually start to use, some form of magnification that's going to allow me to do molar endo properly. And so in 1997, I purchased my first operating microscope. I'd been using 2.5 power loops, and the microscope allows you to work from between 2.5 and 21 power. And the interesting thing is, Howard, you mentioned earlier about India, and I just came back from India. I was lecturing there on endodontics, finding the MB2 canal of all things. And I was amazed at how many dentists were starting to use magnification in India. It was much more apparent. And there were 6 microscope manufacturers at this meeting, 6 different microscope manufacturers, 2 of them that were only exclusive to India. So you're starting to see worldwide an interest in using higher levels of magnification, not only just to do better work, but to improve your ergonomics so you don't have neck and back pain like you or my dad have, and to improve communication and documentation. So you asked about, documentation and how to do it. I can tell you that I couldn't do it without the microscope.
Glenn, my whole passion with Dental Town and everything has been that no dentist has to practice solo again. Use names though. You're talking about 2.5 magnification. I just went this year from 3.8 to 4.5.
Yeah.
And added a headlight. When I'm at my friend's house, when I'm at my friend's offices in Ahwatukee where I'm practices, I mean, they don't even know how many times they're reaching up, grabbing the light. I mean, they do it all during the procedure, and you get that headlight and it's gone.
Yeah.
I don't even care. So, but use name brands on magnification on the wearing them and microscopes. Are they all pretty much the same? I mean, is
it's a good question. One of the things that you were talking about is, and it's an interesting thing, Howard, is that when you look at visual resolution, it's actually the square, x times y. So when you look at the number of pixels for visual resolution, let's say you're using 2 times power loops, it's x times y. So you're seeing 4 times what the naked eye sees. So you mentioned you went from 3.8. Let's say you went from 3.5 to 4.5 times. You go from about 3.5 squared, which is about 10.5, to 4.5 squared, which is almost double the amount of visual information, just jumping that 3.5 to 4.5. When you multiply, say you have 5 power loops, which is really getting heavy now, on your head with a headlamp. But let's say you had 5 power loops, you're seeing 25 times what the naked eye sees, and over 6 times what you would see with 2 power loops. So companies like Oroscoptic, or Designs for Visions, or Surgitel, or Shear Vision, these companies are all making loops that are more and more powerful because they're seeing more and more docs going from 2.5 to 3.5 to 4.5. And if you ask them, they say, yeah, I have one set of loops that I use for my endo. I have one set of loops I use for all my exams. And they have 3 or 4 sets of loops there because they bought the first one, and every time they see the value as they bump up higher.
And Glenn, I actually purchased those for all my assistants and all clinical, all my hygienists, all 3 of my hygienists and all 4 of my dental assistants. They have to wear loops. And to tell you the truth, when I implemented that policy a while back, and some of them pouted a little bit, and now they come up to me and go, thanks for pushing me because I fought it every step of the way. And now if their loops fog or whatever, they don't even feel like they can see a patient. And I have 2 pairs because I seriously, if I walked in there and they said, oh, you won't have your loops today, I cancel everybody.
Yeah.
And then the guy across the street from me has never used them ever,
And you know it when you see some of the patients that come in afterwards, you can tell the quality of the work. And I think that's one of the things that I did it for. I only went to the microscope, and I have 9 global microscopes in my practice. I have 9 operatories. I have a microscope in each operatory. So I have them for hygiene. I have them for restorative. I do 100% of my clinical dentistry through the microscope. The reason I did it was not because I wanted to lecture on it. I just simply wanted to do better work. That guy who I missed the MB2 on, I felt embarrassed, and I wanted to do better work. And it's interesting, when you can see better, you can do better, but you feel much more confident about treating certain things. Certain things come up and you go, oh, there's a fracture there that I never saw, a crack line in that tooth. Oh, there's a decay on the adjacent tooth that I never would have seen had I not had the higher levels of magnification. So I'm not suggesting that everybody needs to start with a microscope, but I am saying that there are a lot of people looking at microscopes now because they love endo, they like cosmetic dentistry, they have neck or back problems, or they simply want to document with videos and stills better, and so they're interested in that aspect. So when I went to India, and you wouldn't think that you would see them there, I saw microscopes in India that were $6,000 US. They maybe didn't have quite the same quality as some of the other North American companies like Global and Zeiss and Seiler and Leica, but they were nice microscopes that had basic bare bone features that would allow the dentist to work on a regular basis using the microscope. So
I
it's
thought
interesting.
I thought Zeiss was German.
Zeiss is German, but they are worldwide in their same with Global. Global is made in USA in St. Louis, and Seiler is also a United States company.
Where are they
Leica
based
is
out of?
St. Louis as well. Leica's out of St. Louis as well. So and
Like
then
you're saying, Seiler,
Seiler's out of St. Louis.
and
Global's
so
out
is
of St.
Global.
Louis.
Huh.
Yeah.
I wonder if they
And
started with the same people, then broke into two.
I don't know. I know that Global's been around since the 1990s. They were a company called Storz before, and they've been selling dental microscopes and ENT microscopes for 15 years now.
I don't think they would sell me one because Arizona stole the St. Louis Cardinals, and now they're the Arizona Cardinals, and now they're stuck with the Los Angeles Rams. So I don't know if they would even take my phone call.
You know what, Howard? One of the things is they might have a couple of runners or people who are Ironman there, and if they read that you just finished your second Ironman in record time, beating last year's pace, they may be back on the phone for you and give you a special deal.
You're a marathon runner, correct?
I was, but my knees are shot now, Howard. I may look the same age as you, but my knees are actually double the age of yours, I think. So.
And that's from running?
No, I actually from playing soccer and hockey as a kid, and then I tore my ligaments, and they're done now. So
I just took my 3-year-old daughter for the 3-year-old granddaughter, Taylor Murray, on the ice rink for the first time, and she did not like that. In fact, she kept saying no, and I put her down. Taylor, and she said no. The whole event lasted 1 minute. We spent an hour getting all of her boots on and getting her all ready, and 1 minute on the ice, and she was done.
See, in Canada, the way it is in Vancouver is a lot of rain. It's like Seattle. But in the rest of the country, a lot of them during the wintertime have outdoor rinks. So you grow up learning how to skate on outdoor rinks in a lot of parts of Canada during the wintertime.
But how old though? I mean, are they doing it at 3?
My daughter was just retired. She was a ice dance figure skater, and she was at the national level, and she started when she was 3 years old, and she retired at 20 or 21 after being at the national level, and so she was skating since she was.
Can you fly her down here to talk to my granddaughter?
Yeah, maybe. You know what? The key thing is, Howard, is to dress your kids up in so much clothes that when they fall, they don't hurt themselves. If they're warm and they don't hurt when they fall, then they're fine on it.
So Glenn, how prevalent is a microscope? Okay, so America has about 4,000 endodontists. I know there's no hard figures, but what would you guess of the 4,000 U.S. endodontists? What percent would you guess have a microscope?
I would say it's approaching 90% now.
Really?
In the U.S. Yeah, in the U.S., I would say anybody that's graduated within the last, I would say 12 to 14 years, it was made mandatory by the American Association of Endodontics in the late 1990s, early 2000 era. They started to make it mandatory that schools taught microscope endodontics. So I would maybe the 2000, that era, anybody who's graduated from an endo program since then will have been trained on a microscope. So from an endodontist standpoint, it's become the standard of care. If you're not using it, it's because
and to the dentist practicing alone who doesn't want to remake a decision, could you go through any market share numbers? Did most of them go? Is it like who's number 1, number 2, number 3? Just for endodontists using a scope.
Yeah, that's an interesting question, Howard. One of the things that I'll tell you is that it matters where in the world you are, and I'll give you an example. For instance, in Germany, Zeiss might be very powerful there. Okay, but in the U.S., I would say that Global is very strong. I would say that Zeiss is always still very strong. In Canada, when I first started, there was nobody else but Global in my area in Vancouver. So Global has a tremendous market share in this area. There's not as many Zeiss users. So it depends a little bit on the area. In the United States, I would say the 3 biggest ones are Global, Zeiss, and Leica is Global, Zeiss, and Seiler, and then Leica is a little bit behind that.
And where's Leica out of?
Leica is a German scope. Very nice optics. They're very big in the operating room, as is Zeiss. They're big OR microscopes. That's where their primary focus is in medicine. But they do have a dental division, but it's a smaller division.
Okay, I know. I can just feel the karma of the questions that are going to be these dentists are going to be saying when they're hearing you. So, Glenn, what do you say to me if I say I'm a general dentist and I don't do molar endo? I refer it all to the endodontist. is a microscope pretty much only for for molar endo in your view, or do you use it? What other things do you use it for? You mentioned earlier you put one in the hygiene ops. Why would you have a microscope in a hygiene op?
Yeah, it's a good question.
I only have one microscope, and that's above the bathroom, and I can't really explain why I need a microscope, but that's a whole nother story.
I don't have any magnification there, Howard. I'll leave it at that. But,
yeah. But why do you have one in the hygiene room?
I'll tell you, one of the interesting things is what we find, a lot of dentists who are very interested in cosmetics, they will look at a microscope. Those who are interested in lecturing or taking video are also interested. But the number one reason is people who have bad backs or bad necks. Because with a microscope, unlike loupes, you can sit vertically, sitting straight up and look straight ahead. So there's nothing on your neck, no weight on your head to pull it down. There's no vertical declination. You can look straight ahead. So the number one reason that I would say a general dentist gets involved in it is either because they really want to lecture or publish and they want to take videos, or that they're very interested in the ergonomics. Now, when you ask me about the hygiene room, why I do it is actually very interesting. Is I have all my microscopes connected to the televisions up above. So when I come into the room to do my hygiene exams, I do a live view, and the patient is able to watch as I'm progressing through their mouth. So it's actually an intraoral video camera with real-time video that the patients are watching. So I like it for two reasons, because patients become educated if they see a filling missing. They don't question me and say, are you sure there's a filling? I don't feel anything. It doesn't feel like there's a problem. I can show them with various magnifications from low to high power exactly what I'm looking at. So it's kind of a cool thing because it is a marketing tool. And in my practice, when I'm working on the patient, I like it because they hold still. Because if they're watching, I have a lot of patients who will watch me working on them. And if they're watching and they move a little bit, they'll see they're out of focus, or they'll move and they're out of focus. So they have a tendency to hold really still. And I would say about a third of my patients to half of my patients will watch it sometime during the procedure. And for hygiene, I like it because I do my hygiene exams with the microscope and the patients are watching. They just switch on the source button on the television and they switch from television to the microscope when I'm watching.
And what's the chance you would ever create an online CE course on Dental Town about just that, microscopes?
You know,
I mean, you have so much free time on your hand. You're only lecturing in India and married and kids and full-time practice. I mean, come on, you could do that between 2 a.m. and 3 a.m., couldn't you?
You know what's interesting is that I talk to people and I say, how many days a year do you practice? And they go, you know what? I'm lecturing quite a bit. I practice about 100 days a year. And next year I'm practicing 214 days in my practice. So all the lecturing is on top of that. So I always laugh because, we're doing this podcast late at night, or not late at night, but after work. And that's where a lot of the lectures and the podcasts. I'll guarantee you that if you want a podcast, an hour lecture on microscopes, I'll do it for you in 2050.
Thanks, buddy. And I'll tell you, that reminds me of dental school. You remember, I hate to say anything negative about dental school instructors because they got a big job taking 100 kids off the street, and then 4 years later turning them legal loose to do root canals and fillings crowns. But it was the part-time instructors that only came in on Friday that were just magical because they were keeping it real in the real world. And then it would seem like the full-time instructors we're just so out of touch. And it's the same thing on the lecture circuit. It's the guys like you who are really real successful full-time practicing dentists that just give a lecture of just one real life pearl after the other. And it seems like all the people who are professional lecturers, they don't have a prototype. They don't have an office. Same thing with consultants. Consultants, they don't have any ownership. It's like, well, where's your practice doing all this stuff? And they just say, well, I've been published 48 times. And it's like, yeah, well, do you have any prototype where this shit actually is proven in the trenches? And man, you are so keeping it real.
What's interesting, Howard, is that one of the things that happens, if you are not doing clinical dentistry, your cases cannot change. And you will show the same material year after year after year. So I always admire the guys that I've heard once before, and when I go and look at their material, it's new because I know they're still practicing. And I always tell when I do training, for instance, on lasers or microscopes, I always tell the docs, I say, you may think that I'm actually lecturing all the time, but I just came from my practice. I'm going back there on Monday, so I'm telling you what I'm doing on a daily basis. This is not just stuff that I've imagined or I've written up. I'm actually doing it on a daily basis. So.
And I would say, you know, I still practice too. I mean, I saw patients this week. I did a root canal yesterday. It seems to me in my office, pretty much everything I do and use only has about a 5-year half-life.
Yeah.
It seems like if you just go back every 5 years, so the hottest, greatest thing today could easily be gone in 5 years.
If you go to Greater New York or Chicago midwinter, when we go to those meetings and you see what's coming, it's impossible when you're on the cutting or bleeding edge to stay completely current. I'll give you an example. About 5 years ago, I had been restoring implants for a long time, and I had a number of people who said to me, especially on the lecture circuit, how come you're not placing implants? So I went and got courses, did some one-on-one mentorships, took for the last 5 years taking courses, and bought a cone beam and started placing my implants because I realized the direction things were going was that I could provide those patients in my practice with an opportunity to replace a tooth that was lost with an implant, or I could refer them and have them go home, talk across next door to the neighbor who says, you know what, my dentist does implants. Why don't you go and see him? He doesn't charge as much as a specialist, and I would lose him. So you have to have a passion for the profession, and you have to constantly want to keep changing. That's one of the beauty things with Dental Town is if you develop a passion, let's say it's molar endo, you can go to the endo forum. Let's say it's implants. You go to the implant forum, and you can read a lot of people who will provide you with material that is really cutting edge stuff that you can stay current and get excited about dentistry. I'm always amazed by guys that are still doing the same thing that you and I learned about in dental school. You know, amalgams, PFM crowns, gold crowns, dentures. To me, if that's what I was practicing on and I wasn't able to constantly change and morph and grow, I think it would be very boring.
You know, when I got out of school, you know, people are always saying, oh, it's the golden age of dentistry. And now I think it's really the titanium age of dentistry. And what I'm most excited about titanium is one of my biggest pet peeves on dentistry that I'm always trying to get dentists to think about is it seems like most people talk about dentistry as if they were an engineer. It's all about, you know, it's engineering. It's mechanical engineering. Yet everything I see in my private practice, dentistry is about biology. I mean, dentists will talk about the margin not being perfect and it'd be a source of recurrent decay. Dude, the tooth was taken out by bacteria when there was no margin. I mean, I always say when termites go hit a barn in Kansas, do they go to where the barn door has a crack with the barn wall and say, well, there's an entry point. Let's go in the margin of that barn door. They just eat through the whole wall. I mean, all day long, it's like, I feel like I'm a biologist. I spend my whole life trying to kill gram-negative anaerobes. And what I love about titanium is, Glenn, the bugs can't eat titanium. And when I go, there's about 8 nursing homes in my area that I have to go into seeing, 70, 80, 90-year-old ladies that I treated for 25 years. And I'm telling you, Glenn, when the implants and crowns I did, they're all perfect. But the root canal buildups and crowns I did, about 18 months after they're in the nursing home, root surface decay is pretty much, I mean, they're reduced to mush.
Yeah.
Are you seeing that?
You know what? In my practice, about 16% of my practice is over the age of 80.
16% over 80?
1/6, yeah. Now, the reason being is that my dad was a dentist, graduated, and I took over his practice, and I've grown from a 2-chair practice to a 9-chair practice. So a lot of those patients who were patients when my dad started in 1961, they're still patients in the practice. So I have a 100-year-old patient who last year I did a crown on because she kept busting the filling out of the front tooth, and she wanted a crown. So we did a crown on her. Well, when you look at the problems that happen with the older population on their teeth, from dry mouth, all the medications they're on, Alzheimer's, they can't remember whether they brushed or not. I'm dealing constantly with, I have a consultation with somebody tomorrow who's upset because both the lady who's in her early 80s and her husband have got dementia, and they cannot remember that one of the associates told them to take that tooth out. And now they're upset because the partial doesn't fit anymore, even though that tooth was unrestorable. So I have to spend half an hour trying to say to them, yes, I understand that, but the reason we did this is because your tooth was unrestorable. So it's a big problem. One of the interesting things, Howard, is that nowadays I find that patients don't take, they feel entitled, but they don't take responsibility for the problems. It's always the tooth you worked on. So the best job that I can do when we come back to the microscope, the best job I can do to give you the longest time, and if I tell them that the average crown, the insurance plan will pay for every 5 years, but I did that crown 18 years ago, it's triple the time, then there's already this relaxation. Well, yeah, okay, it's 18 years old. So that's what I'm always trying to do, is extend the lifetime of that tooth. But I totally agree with you. When the patients get older, we're dealing with a lot of problems.
Well, Glenn, I want you to make a comment on something, and I'm going to warn you ahead of time. Be careful what you say, because this is probably the most controversial thing I ever said, but on a Howard Speaks monthly column. I've had a monthly column since 1994, and probably the one with the most viewer hate mail was, when I see 85-year-old ladies in nursing homes, they'll go in and they'll get 5 class 5s, and the dentist will do composite. Yeah. And there's no active ingredient. And I say, and the research says, if they would have done it with amalgam or Glastonometer, they would have been, and these dentists say, well, I don't have amalgam. And I'm like, okay, you're still doing cosmetic dentistry on a lady with Alzheimer's, dementia, rheumatism, can't brush. And if you're a doctor and you're doing class 5s on people who don't even know the names of their children in inert plastic composite because you're amalgam free, you're not amalgam free. You're a freak. You're an extremist, and you're not a real doctor. And I called the dentists who don't have amalgam that they're not real doctors. And oh my God, I bet I got 1,000 hate emails about it, but I still stand by it. I mean, the lady doesn't even know the name of her own children. Amalgam, it's actually not the mercury that's or bacterial static. It's not the copper, the silver, the zinc. It's the tin ion. That's why we have stannous fluoride in mouthwash. And it's the tin ions flying out of the amalgam that are some level of bacteriostatic behavior. And the dentist will say, yeah, but when I take out those old amalgams, there's like black scuzz underneath it. I'm like, excuse me, is black scuzz a species? Does it consume glucose? Does it eat on the Krebs cycle? I mean, really, you're a doctor of dental surgery and your biology is black scuzz? Furthermore, that black scuzz was under amalgam that was 38 and a half years old. Yeah. I mean, really, we're retreating amalgams because there's black scuzz? You're not even a doctor when you say black scuzz. And I think the 4,000-pound elephant in the United States and Canada and the very rich developing countries is that there's just a gazillion ladies between 85 to 100, and all that dentistry we did from birth to 65, we need to rethink that whole thing. You don't really have to on a man. I mean, their average life is 74, but in America, the women are hitting 80 now. That's on average.
Yeah, and I have many 90-year-olds in my practice, Howard. I have many 90-year-olds, and one of the things we see is root caries. When I first started my practice in 1987, most of the patients, if they made it to 80, they had dentures, because they grew up in an era where they didn't go regularly to the dentist. When they did go, it was an extraction. So many of them had dentures. In fact, I remember a guy who came in for his reline for his dentures, and he told me, I said, how are you doing? He said, great. He said, just turned 80. And I said, well, that's fantastic. It's quite a milestone. And he said, if I'd known I was going to live this long, I would have taken better care of myself.
Oh, yeah.
And the interesting part is that I've started to notice now that more and more of the generation that's retiring now is, one, living longer. Two, they may even live longer than us because they're taking better care of themselves. A lot of the patients are not drinking a lot. They never have smoked. They worked, but they didn't work these crazy hours. But what I'm finding is that they're getting root caries. And for me, in my practice, switching a little bit the tone of thought, the microscope and magnification is very important. But for me, a laser on the class 5s and using a laser to remove the soft tissue and do gingivectomies to keep the field dry helps me an awful lot when I'm putting Glastonometer onto those facial surfaces, to keep the surface dry and to be able to get that material in there.
Okay, let's slow down that, because what you just said in a minute, a lot of these dentists, it would take an hour to explain what you just said. So let's talk about, first of all, explain to people, you're ICU lecturing all around the world. Obviously, Australia, New Zealand, Japan, they use a lot more Glastonomers. They say things like they have that filling called a sandwich, where they'll put Glastonomer on the bottom and air composite on top. When you go into America in a room full of dentists, can anybody explain the sandwich technique? No one even knows what you're talking about. So, Glenn, explain the difference to dentists around the world in every continent the difference between glass ionomer fillings and composite fillings.
Well, one of the nice things for adult patients when you worry about recurrent caries is that very rarely do you find recurrent caries underneath a glass ionomer because it's releasing fluoride. And so whether you use that in the base of your boxes on class 2s or whether you use that as on a high caries rate patient for class 5s, it's really nice material to prevent recurrent decay. So you had talked about amalgam and glass ionomers. I like glass ionomer for those patients where
But Glenn, are you really going to stick to those words? I mean, you just said you don't sell. Did you say never find or almost never find recurrent decay under a glass ionomer? Well, if that's true, why would anybody not use a glass ionomer? Because again, dentists, it's like if you go to a Gordon Christian seminar. I mean, he always talks about all the wear rates of fillings. Like this wears at 15 microns, this wears at 20 microns, this wear. Well, my problem isn't the fillings all wore down. And then they talk about bonding strength. Everything's like megapascal bonding and megapascals. And the dentist saying, well, I'm going to buy this one. It bonds at 27 megapascals and this one only bonds at 20 megapascals. Like my fillings aren't falling out. That's not my problem. My problem isn't the fillings wearing down and falling out. My problem is that they're invaded by bacteria. Hundreds of millions of gram-negative anaerobes eat this whole thing out. It's a biology problem, not an engineering problem. So again, are you pretty much only doing glass ionomers then?
No.
Or are you looking at the Canberra Caries Index, or does that play into?
We don't have that. I know in California it's a big thing. We don't have that here in Vegas. I know Kim Cooch and his group, the minimally invasive people, have looked at caries rates in different people, and guys like Graham Milicic from New Zealand, etc., are big proponents of glass ionomer. If the patient is a high caries rate, that you're constantly redoing class 5s and there's caries going on, and the patients who have medications that have dried their mouth out, patients who aren't brushing at the gingiva and they're at a high risk, the glass ionomer materials are much more able to withstand caries. My dad used to use silicates. You never saw caries underneath the old silicates.
And why is that? Why is that? What did
because again, it's releasing fluoride in there, and when you see these materials, they stained. The patient was walking out of the office and they were already staining. But when you take those materials out, they wore quite fast. But if you took them out, there was very rarely caries underneath them, like composites.
Okay, Glenn, there's a dentist out there saying, Glenn, be specific. What's the brand? Can you walk through real quick a class 5? Walk through the technique with the brand of a class 5 on an 85-year-old lady with Alzheimer's that has root surface decay on 8.
And one of the things, what I'll do is how I use primarily, I really use diode lasers a lot for tissue management. And I think that's one of the key things for me is in many of these patients, the caries goes subgingival and I need some form of laser. And as you know, I lecture, that's probably my primary area of lecturing now is not so much microscopes and magnification, but lasers. So for me, the soft tissue laser is essential for removing the soft tissue, doing a gingivectomy, getting that out of the way so that I can see the apical portion of my prep. And then what I like to do is some people like to.
But I got to stop right there. You're talking about the benefits of removing the tissue so you can see what you're doing.
Yeah.
But when you're done doing it, that gram-negative anaerobe, the number one thing on Earth that it hates more than anything is atmospheric oxygen. The atmosphere is 20.9% oxygen. And when you remove that tissue, gram-negative anaerobes, they're anaerobes. They don't live in oxygen. They're not going to go up there and eat with all that oxygen up there. So it's massively, it's making an environment where it's going to be hard to fail.
Well,
harder to fail.
All lasers are antibacterial. All lasers. So when you put a laser inside an endodontic tooth, it kills the bugs. When you put a laser inside a periodontal pocket, it kills bugs. So all lasers are antibacterial. And so one of the nice things is not only do you get a low-level laser therapy with the laser on the soft tissue, you kill the bugs around there, so it gives a nice environment for it, and it keeps the class 5 lesion visible and without crevicular fluid or blood, which is even worse, creeping into the class 5 lesion, so you can put your restoration in. I like Fuji products. That's what we have in the office, Fuji 9. We like to use that as in our class 5s. in the situations where, composite resin on a nice looking lady who's in her 30s and 40s, maybe you don't want to do that. And maybe in some cases you want to graft, but for these older ladies where you're trying to do something to help them maintain that tooth, Glastonometer is a nice material.
Okay. So again, diode. So diode is soft tissue, carbon dioxide or carbon dioxide for hard tissue. Is that generally?
Yeah, it's a good question. In dentistry, there's 4 different wavelengths. Okay, and these are 4 different categories of lasers. Diodes have become very popular, Howard, because they're small units that are, in many cases, they're portable, and they allow you to use them as a soft tissue handpiece as opposed to an electrosurge. Electrosurges aren't great around metal, so you cannot use them very well around implants, amalgam, gold crowns. Electrosurge always needs anesthetic. So unlike a diode laser where you can remove small amounts of soft tissue without anesthetic, electrosurge always needs it. You can use a diode laser with pacemakers, whereas electrosurge you cannot use with a pacemaker. And finally, electrosurges aren't antibacterial, whereas diode lasers are. So diode lasers, as the price dropped A.M.D lasers dropped the price in about 6 years ago, and all of a sudden there was a massive influx because people said, I don't have to spend $10,000 to buy a laser. A diode laser now is $3,000.
Now
or less.
You said A.M.D laser?
Yeah.
Is the AM for their unbelievable CEO, Alan Miller?
Alan Miller.
What was the D for then?
The D was Alan Miller Designs.
Alan Miller Designs. And that guy, if that guy isn't one of the smartest guys in dentistry, I don't know who is. That guy is amazing. And what did he do to the price point? When I got out of school, a diode was $50,000. Yep. And what is an AMD today for a diode laser?
That's about $3,000, yeah, for a 2.5 watt laser. Howard, I'll tell you an interesting story.
And you did that in Indiana. To think of Hoosier did that.
Yes. Can you imagine? Amazing. Howard, I'll tell you a story. When I first got my first laser, this is an interesting story. It was 1998. It was an argon laser, and that was a large unit. It was 220 pounds. That laser cost me $54,000. It was single op. You couldn't move it. It did 2 things. It cured resins, because at that time we didn't have LED lights, so it cured resins in 3 to 5 seconds, so it saved you time. And secondly, what I used it for was it had a cutting mode, a green wavelength that would cut. It was very hot, and the laser, as the argon gas dissolved and left, you couldn't use it anymore. So that was $54,000. We used to call it the Zamboni, the machine for cleaning the ice rinks, because it was so big, it was massive. So now you have these little 2.5 pound diodes that are replacing soft tissue electrosurge units, and they can be used for all sorts of nice little contouring, for crown troughing. I didn't use cord last year at all. We always use the laser for troughing around our crown preparations. We use for class 5s, for gingivectomies, for nectomies, lingual tongue ties. We do a lot of tongue ties on kids too.
How often do you talk to Alan?
How good do I talk to him?
How often do you talk to Alan? I mean, is he
once every month, maybe?
Will you do me a favor for Alan? I have a dentist probably every 3 or 4 days telling me he wishes their certification program was online on Dental Town. They have their staff as opposed to having CDs and assistants come back and saying I don't even have a CD because I use Netflix and whatever. People don't have 8 tracks and cassettes in their cars anymore. All that stuff needs to be online. So I just want to say one more thing about the electrosurge. I've done this about maybe 8 times in the last 10 years where a dentist says, I use electrosurge. My biggest complaint with the electrosurge is post-operative sensitivity. Yeah. And then dentists will tell me, well, I don't get that. You're doing it wrong. I'm always doing it wrong. So then I walk them up front and I say, give me the name of just one person you used the electrosurge on last week. And the receptionist say, oh, it was Glenn Van Ass, because I remember because he called yesterday wanting a refill on his Vicodin.
Yeah.
And then I'll call the guy and I'll say, does it hurt? They go, oh my God, it's the worst pain. And the dentist, they don't hear that. And they might call back the front and say, is this normal? And the paper isn't, the office isn't paperless. So she doesn't want to pull a chart. So the dentist never gets his feedback. Whereas I actually went paperless in 1999 just because I gave up. I kept telling my 4 receptionists, every conversation you pull the chart and you note it, and it just never got done. It was too time consuming. So I only went paperless so that when I had the patient come back in, I could see the conversations, if they were upset about the financial arrangement or whatever. And Electrosurge, do you agree or disagree that it causes a lot of postoperative discomfort compared to a laser? Do you agree with that?
I'll tell you. One, they say that a diode laser has 1/5 of the lateral thermal damage that an Electrosurge has. The second thing is I did a lecture many years ago, and it was a large audience, and in this audience was a lady and a young daughter. And I thought it was weird that this lady was a laser lecture that she was sitting in. And at the break, she said, I'm really amazed by your frenectomies and your healing, because I do a lot of infant frenectomies, and I'm talking 3-week-olds where they can't latch on. And so we do a lot of lingual tongue ties or upper lip ties for very young infants who are having problem latching. It's amazing how rampant this problem is. There's a lingual tongue tie group, and there's 23,000 people on it. So when I looked at this lady, she said, I'm amazed by your healing. When you show those 7-day healings, she goes, here, and she says to her daughter, she says, show him. She said, she lifts her lip out, and it looks like hamburger. It's so bad. And I said, oh my gosh, was that done yesterday? She said, that was done 1 week ago. She hasn't been at school all week. And she said, I couldn't send her to school today, so I brought her with me. And I was just appalled at what I saw in terms of the amount of thermal damage that had been done just with the unit there. So, that's the old style. I think, with lasers nowadays, you really can do a nicer job, less post-operative pain, and less risk of any infections.
And I just want to add one thing, because I'm always used to dentists. Dentists are always right, and I'm always wrong. I mean, my name's Farran, and I'm wrong. A dentist in Vegas, I'll never forget, it was about 10 years ago. And he said, well, you know what the trick is after you use the Electrosurge, you just run cold water with your 3-way syringe on it. And I always flood it with cold water, and that gets rid of all the postoperative pain. And his assistant standing right there, I said, did you use it last week? Did you do that? Got the name. We went up front. We called the patient again, completely throbbing. So, if you cut your ears off and don't listen to anybody, Electrosurge might be a great idea, but it's not a great idea. In fact, would you declare that Electrosurge is done in dentistry?
Yeah, I will go on and say that Electrosurge does 2 things well. It cuts gross amounts of tissue faster than a diode laser. And secondly, you don't need safety glasses for it. But other than that, you can't use it around implants. If you are doing any implants and you have to do soft tissue remodeling, if I'm talking to you today and one of my patients phones and says, oh, my crown came off, but it's not bugging me on my implant, it was cemented, I'm going to come back and see you tomorrow. By the time they come in tomorrow, the tissue is so closed around the abutment, you cannot get the crown back on. I don't know how you're going to get that on if you don't have a diode laser, because you cannot use Electrosurge.
And by the way, that mouth tissue is the fastest growing tissue in the human body. You usually get primary closure in 24 hours. You said originally 4 lasers, but then you talked about diode. So let's go to 2, 3, and 4.
Nice soft tissue, and it's an entry point. Other lasers include a CO2 laser, and those are either completely soft tissue, or there is a new hard tissue laser from a company called Convergent that is a CO2 laser. I have not used it. It's a big unit. But those lasers, the CO2 lasers, the soft tissue ones are fast cutting, and oral surgeons like them because they're fast. The next laser is an Nd:YAG laser, and like the main laser that people know about that one is the PeriLase, and it's used for periodontal therapy. They're big proponents on Dentaltown. They've got a large user group that are very fanatical about using their product and their protocol for LANAP. It's laser-assisted new attachment procedure, and that LANAP protocol is with their laser only. And then the final laser, which I'm using a lot, is a hard tissue laser. It's called the erbium laser. One of the best-known companies is BioLase, and I'm using a BioLase I+. And it's a laser that can be used for cutting soft tissue, bone, tooth. It's kind of an all-tissue laser.
Are you friends with the owner of PeriLase?
Yes.
Are they
Bob Gregg?
Bob Gregg.
Yeah.
He's in Colorado.
No, he's in Cerritos, California.
Okay, and that's the one with the adorable wife. That's always with him. Yeah.
Dawn Burke. Yeah.
Yeah. You know my problem with PeriLase is if you really want to learn more about it, you have to commit and go and buy. And I just meet so many dentists that do it and love it and just praise it and just say it's the greatest thing. And that's what I call the low-hanging fruit. But it seems like the next level, they want more information to get into this. And their system of information is like, well, once you've bought and once you've committed, and then we'll train you on. It's like, I wish there was a more intermediate amount of information, because I think they'll get a whole nother tier of dentists if they can see and understand more than what they buy. Dentists, they're engineers, scientists, physicists, and a lot of them need a lot of information to buy. And it seems like that's most of their information. You have to cross an economic barrier of purchase before you really, is that a fair statement, or do you think that's not true?
I think it's fair. I think one of the interesting things, Howard, is that in the last few years, their market has been primarily periodontists. They have about almost a quarter of the periodontists in the U.S. now own a periolase. And why that is because a traditional market, and when I graduated, the periodontists were trying to save teeth. But as implants came into practices and connective tissue grafts became more commonly used, periodontists' focus changed from trying to save teeth to implants. I knew periodontists who told me they were placing 1,400 implants a year, and now they're only placing 400, 350 a year. You know why? Because all the GPs are learning how to place implants. So many of the periodontists now are looking and saying, okay, my chairs are empty. I better start looking back at trying to see alternative mechanisms for trying to keep patients in my practice. I'm going to try and save teeth. So the periolases, they've really focused on periodontists. I think in order, once that gets exhausted and it sort of hits critical mass, maybe 50% of the dentists or periodontists have bought them, now you have to look at where am I going to move next. And really for those who have a high number of periodontal patients in their practice, it is a very good laser. 90% of teeth, 90% of the pockets will shrink by 50% in one visit. So, if you've got an 8mm pocket that can go to 4, and it's from the bottom up, bone fill, that's pretty impressive. So 90% of the pockets in their studies, and again, I'm not a spokesman for the company, 90% will go to 4mm. You can, Howard, I will say, because I do work with BioLase, I will say that BioLase also has their deep pocket therapy that they are promoting, and it is using side firing tips to not only remove calculus and remove the inner wall of the pocket, but they can use their laser as well to clean the root surface, and they're also getting tremendous results with their laser periodontal therapy. They maybe don't have the few studies, well-researched studies that the periolase has, but you can do periodontal therapy with a hard tissue laser and get nice results.
Well, it's funny because since I'm 52 and graduating in 87, I see this business strategy deja vu again. Because remember when Brandmark from Sweden, when he first started teaching implants in America, he'd only teach oral surgeons. And if you knocked on the door and you're a general dentist, like, get out of here. And now he's 85 years old in Brazil. I was emailing his wife the other day, and they eventually realized that, the market's going to general dentists. And now more general dentists around the planet place more implants than any specialist. But I want to pin you down on something that there's a lot of kids in dental school. One of the biggest questions dental students ask me is there's 9 specialties that the ADA recognized. They just added a new one a few years ago, oral radiology, because of the advancements of 3D, CBCTs. Yes. But I got to ask you, and I hope there's no periodontist listening to this, but what would you say if your daughter was a senior in dental school and she said, Dad, I think I'm going to go be to perio grad school and spend 3 years being a periodontist? I mean, you said it was the end of Electrosurge. Are you kind of seeing the end of perio, or would that be the least defensible of the 9 specialties to go into? I mean, I tell them to go into oral radiology because I got a CBCT, and Glenn, I'm telling you, it's like getting a microscope and looking out in the universe, and 3/4 of what I'm seeing is dark matter. And I mean, I'm not, we had 3 dentists the other day, and we were looking at a CBCT, and there was this one huge structure. 3 of us didn't have a clue what it was. I mean, no idea. So I always put him in a Dropbox and send him to Dale Miles, who's an oral radiologist, to say, just so I'm not missing something. But so I think CBCT is good. But what would you say to your own daughter if she said, Dad, I think I'm going to be a periodontist?
It's interesting because as a specialist, the traditional way that general dentists worked is they dealt with things that they dealt commonly. So, for instance, if they did a lot of restorations, they did extractions, but if it was a difficult patient, medically compromised, or difficult procedure, they might refer them. You're seeing a lot less of that now because once the recession hit in 2008, people are trying to keep patients in. And I know, for instance, in Canada, and where I live in Vancouver, some of the practices on average have 500 patients. So how can you survive with 500? You're going to make sure that you try and keep that patient in. So you're not less so likely to refer that patient to the periodontist with the risk that the patient's going to go to another general dentist and not come back to your office. So I think all specialties are suffering. I don't think only perio. I think all of them are suffering, and they're all having to learn new things. So I see orthodontists that are doing other things. They're doing laser frenectomies. I see endodontists who are placing implants. I see prosthodontists who are placing their own implants and not just restoring them. Why? It's all because as they're traditionally general dentists have started doing more and more of the procedures and becoming kind of a jack of all trades, they're referring less and less. So I don't know if it's only perio. I think pedo is still strong because there's still a lot of kids that require special treatment. But orthodontics, general dentists are taking a lot of the ortho as well. So it's not just perio.
Man, my favorite specialty is the pediatric dentist. You know, God bless him. If I had to do that, Glenn, I would quit and work at McDonald's third shift. I mean, like, oh my God. But I want to tell you something about endodontists. You know, I have an MBA from Arizona State University, and you know, they just beat into your head that, you know, 80% of all decisions come down to price and you know, prices. You know, in MBA school, anybody can get an MBA because if you walk into any multiple choice test and you just put price on everything, you'll probably get an 80 on your test and get a B. And I have seen too many times that I have sent a patient to an endodontist and they'll just retreat. And then when it fails, a year later they say, well, you know, I did the best I could. And it's like, well, you also took $1,000 from them or $1,500 and it didn't even last a calendar year. And I only send endodontic patients now to someone who can say, well, I'm not going to retreat this. I'll make my $1,500 by pulling in place an implant. I want that endodontist to be able to make the same amount of money pulling the tooth or retreating the endo. And when the only way they can make their money is a retreat, there's too many retreats done that don't have a meteorite's chance in hell of surviving.
100% agree.
Yeah.
100% agree.
So be leery of the endodontist. You know, if your only tool's a hammer, everything looks like a nail. And if the only way you can make money is to retreat a root canal, that scares me. Do you agree with that, or is that too harsh of words?
No, I agree. I think one of the things too, Howard, is you know, in the journal, I think it was the Journal of American Dental Association this past year, there was a study that came out that showed that the actual failure rate amongst general dentists for implants was 19%. So they were showing that, you know, sometimes the pendulum may have swung too far, that we're taking out teeth that we really should be trying desperately to save, and we're taking them out, putting implants in, and that the failure rate, there's a guy named Massimo Simeon, and he's from Italy, and he's talking about the tsunami of PeriImplantitis that's coming because there's so many GPs taking weekend courses and putting implants in. So, you know, you kind of have to find a balance between those teeth which you can treat and those teeth which you can't treat. And, you know, one of the biggest things I'm dealing with now when I'm on the lecture circuit, Howard, is PeriImplantitis and laser treatment in that, and using hard tissue lasers like the BioLase I Plus to remove granulation tissue around implants, disinfect the implant surface to allow for regrafting and opportunities to save the failing and ailing implants. That's
one of my favorite sayings is that the mind is like a parachute; it doesn't work till it's open. And one of the key words one of our listeners might not have heard is you're not calling it periodontal disease; you're calling it PeriImplantitis. And a lot of people always talking about that. Oh, you know, there's some gum disease around this deal, but you know what? Gum disease around natural teeth is very different than around a titanium, and you're calling it PeriImplantitis. So, Glenn, will you talk about the difference between periodontal disease on a human natural tooth versus PeriImplantitis and how they're different, and are they treated differently?
Yeah, it's a great question, Howard. Really great. One of the things that I always joke, Howard, you know what the difference between an ailing and a failing implant is? Well, the ailing implant is one that you did, and the failing implant is one guy down the street did, you know? But the reality is when you look at the gingival fibers around an implant, those fibers typically are not horizontal like they are on Sharpie's fibers on a tooth. They're vertical. So I always tell the patient, you get a popcorn kernel stuck in a natural tooth, there's a defense mechanism to prevent it from going down. Same with the crown. If you had a little bit of extra cement stuck in on a tooth, it won't go down halfway down the root surface. You get a little bit of cement stuck on an implant, and you can push it halfway down the tooth and get a lot of problems. So when you see implants, you see not only mucositis problems, which are not a lot of bone loss, but gingival inflammation. Those can be cleaned up by simple methods, non-surgical methods. But when you look at failing implants right now with bone loss, once it gets beyond 50%, doesn't matter what you do, you might as well extract the implant and start over again. And there is a lot of effort now looking into how do I get rid of the granulation tissue? How do I disinfect the site? Because it's got so many threads, and you need the hard tissue lasers are able to disinfect the threads completely and allow you to graft material back on. So there's a lot of excitement over lasers like the BioLase, the erbium lasers for disinfecting implant surfaces in a surgical manner on implants. So it's really something that I'm lecturing a lot about right now, and it's an exciting topic.
Do you think the bacteria, the bugs around and failing implant are the same as the ones around a failing tooth with peri? Do you think perio and PeriImplantitis bugs are similar, or?
That's a good question. I don't think that they're similar, but I do think that when it happens around an implant, the machine surfaces are rough to aid for osseointegration. But what happens, those same roughened surfaces are very difficult to keep clean once the bacteria get on them. So they just start to travel down. And I think the bacteria that you have for PeriImplantitis, I don't think are going to be the same bugs that you find for PeriImplantitis. But the mechanism is much more aggressive, and you see a lot more of it than people want to admit. And I always tell people, if you're not sure, press on your implant on the buccal surface, and you'd be amazed how many times you get something coming out of the sulcus. And the patients that I wasn't even aware that was happening. And the microscope, when I have that hooked up and they press on it and they see the pus coming out, I had one today. She was literally crying. I didn't do the implant. She had this implant done, and I pressed on the buccal, and I said, "You see that white stuff coming out of the gum?" She said, "Yeah." She said, "I get a bad taste from it." I said, "That's actually infection that's draining out of your bone."
Okay,
So
I'm always listening to you trying to predict what 1,000 dentist questions might be around the world. You said implants have different surfaces for osseointegration. There's somebody out there thinking, well, which implant do you use? What surface did you go to? Did you get a HA-coated implant? What type? What name brand? What surface did the wise Glenn Van Ass pick for himself?
I used to use Ankylose a lot, which is a Dentsply product, and I liked it. It had really nice bone maintenance because of the way it was. And guys like Bill Schaefer on Dentaltown use Ankylose, small 6mm Ankylose implants. He does amazing stuff with his sinus lift and his short implants. I used to use Ankylose a lot, but I found from a cost standpoint it was tough to compete, and a restorative standpoint it wasn't the easiest to restore. So I went to a lower cost implant. There's a number of them out there, things like Implant Direct. Blue Sky Bio is a big supporter on Dentaltown, but I use a product called Hyosin. It's a Korean company. It's a less expensive product.
Spell it.
Hiossen. Hiossen.
Hiossen.
Yeah.
So it would just be hyosin.com.
Yeah, and it's the 6th largest implant company in the world, #1 in Asia and a lot of the countries, because it's a very similar surface to Straumann, but it's probably a third the price of Straumann. So I'm able to compete on price. We talked about price, and comparing myself to a periodontist. I can't compete on experience with a periodontist who's placing 1,400 implants a year. I might place a couple hundred, but I can compete on price, and I know my limitations when excessive grafting needs to be done or vertical augmentation needs to be done. You know where that's going.
So Glenn, I got to ask you, the guy who really started implant revolution, wouldn't you say that was the guy I just said his name, Dr. Brandmark in Sweden?
Yeah.
And he named it Nobel Biocare because Sweden's the Nobel Peace Prize and all that stuff. And then Straumann is from Sweden. That's where it really, right?
Switzerland. Straumann's from Switzerland.
Oh, Straumann's from Switzerland. I always get those S's mixed up. I'm sorry to all the people from Switzerland. But why do you think the largest dental company in the world, Danaher, just paid $2.1 billion for Nobel Biocare when it's one of the highest cost people, and they also already own one you just mentioned, the Implants Direct? What does Elizabeth think if they own the low cost Implants Direct, which Glenn Van Ass says, low cost? Why would they own that and then pay $2.1 billion for Nobel Biocare? What was your thing? I mean, no one. Only Danaher would know, but what would your guess be?
Well, I think, when you look at a lot of the specialists, they are loyal to the big three, and the big three being Straumann, Zimmer, and Nobel. And they're loyal to them because from a surgical standpoint, they're placing implants. The dentist will say, I don't care what implant you place. You place an implant for me, make sure it's a good one. So they'll place those. a lot of the specialists will get a good deal on the implants, but the restorative dentist has to pay full price for the restorative fees. So a lot of times the patient comes back from the specialist, says, I paid X amount of dollars, and he says, how much more am I going to need for your restorative aspect? So a lot of dentists are looking for alternatives now. One, keep the patient in their own practice, do the implant themselves, and two, get a lesser priced implant. So when you look at Danaher, I think they're looking at primarily the specialists, the people that are continuing to use Nobel, because I do know that these big companies are struggling right now because more and more of the general dentists are switching to lower cost implants in an effort. Patients don't ask you what implant they use. They don't ask you if you're replacing Straumann. Nobody does. They ask you one question, the same question you talked about with the multiple choice in the MBA. They ask you, how much do you charge for an implant? Because it's not covered by most of the insurance plans. And so they don't, do you know there's 400 implant companies in Italy? 400. There's over 1,000 implant companies.
400 implant manufacturers in Italy?
Yes, 400. And there's
Holy
1,000 implant
moly.
companies worldwide.
Huh.
They all work. They all work.
So Glenn, you just said they all work. Glenn, are you saying that titanium is titanium and an implant's an implant, and if Implants Direct sells it for 100 and someone else sells it for 200, 300, 400, they're all titanium screws? Are you going that far?
I'll just say that the surfaces are different. Okay, but all implants will osseointegrate to a greater extent. Now, if you took Straumann, maybe their success rate is 97%. Maybe they're one of these lower price companies, their success rate is 96% or 95%, but it's not 75 or 35. And so the difference is less. The differences between these companies are in their restorative capability, their service and support, their education, their commitment towards education. So those kind of questions, are questions on the differences between implants, but they all work. Now, some people will have a real preference for one implant system over another. I like the High Austin system because it has an SLA surface, and they are doing some pretty cool things with some of their surfaces, like BMP2, that they're going to start coating them.
Bone morphological protein?
Yeah, they're going to start coating them with that. So you might find in the next year that these products are coming out, and they're finding in Korea that the products they're loading at 4 weeks, because patients are always saying, how long before I get my crown? And when you tell them it's going to be 3 months before I can load that tooth, a lot of them are like, can't you do something earlier? So some of these implants companies are looking at methods to try and get loading earlier than 12 weeks.
Well, Glenn, I can't believe we're out of time. That was probably the fastest hour I ever spent in dentistry. I just want to say that in all seriousness, I'm not blowing air. You're one of my biggest rock star mentor idols of all time. I'm a huge fan of your 7,314 posts on Dental Town. You're a legend in so many people's minds. Probably most dentists, if you say, name a dentist in Canada, they're only going to say you, the great one, Glenn Van Ass. Thank you so much, Glenn, for putting me on. It's dark. You did an hour at the end of the day. Bless your heart. Thank you so much.
Hey, Howard, let me conclude by saying one thing. I started on Dental Town in about 2002, and I started because it was nice to have communication with other like-minded dentists about various topics. I want to thank you for that. But I'm going to tell you that the most amazing thing that I never knew would happen is how many people I'll meet on a lecture circuit, and they will say one thing to me. They say, I read your posts on Dental Town. It's like I knew who you were before I even met you. And that has happened to me 100 times, if not more. And that's because you started a web forum where no one dentist ever had to practice alone, and where you had the opportunity to share information in a collegial fashion and get information on whatever you wanted about dentistry, be it practice management or clinical techniques. And really, you were the visionary that saw that, and you've built a tremendously successful web forum, and I want to thank you for your efforts.
Well, thank you. We should start the Mutual Admiration Club because I love you like a brother. Thank you so much, Glenn, for an hour of your time.